Thanks and good morning. I guess that leave me a whole hour to speak. No, just kidding. Firstly, this is a very long week for all of you, so I'm glad that this is like the first real day and you're still all bright. Dr. Sheesh actually spent a lot of time talking a little bit about kind of the broad general overview, so I'm going into more granularity of some of the specific cardiomyopathies and myocarditis. Why do I spend this time? Because I think most of the time people do recognize that these are kind of some of the most popular topics that is used in the boards. As well as a lot of times we do see these patients on a regular basis actually in your practice. Some of you may not necessarily appreciate. You may think of somebody has a primary like lupus nephritis that comes in with cardiomyopathy, or other times when you see somebody come in with new onset heart failure that you don't think too much about specific cardiomyopathy. So I think the boards do recognize that you need to know at least some basics of maybe some alterations or specific considerations, and that's why this is quoted this way. So cardiomyopathy is actually quite a young field in the sense that there has been a lot of correction or changes in the definitions. Originally, it's really a pathologic diagnosis. You can actually see two very different explanted hearts. One is very dilated, and the other one is very thick. And yet, both patients can actually present with very similar symptoms that is previously described in the previous lecture. So in some ways, the diagnosis is heterogeneous. It's a group of disease for the myocardium associated with mechanical and or electrical dysfunction that's usually, but not invariably, exhibit inappropriate ventricular hypertrophy or dilatation. There's a pathologic consequence to it, and are due to a variety of causes. So it's a very, very vague definition. And the main reason because of this is because it actually comprised of many systemic diseases as well as a lot of very specific cardiomyopathies, either genetic, acquired, or mixed. And that's really the first diagnostic criteria for primary cardiomyopathies. That's something intrinsically wrong to the heart. Of course, there's a laundry list. Don't need to really read it in fine detail, but you can see the majority of what you deal with in medicine really can cause some degree of cardiomyopathy. I'm going to go over a little bit of them down the road. Why do we care? Because it does give a big difference in the outcomes of the patients. Different patients do have different clinical course and different manifestations. And sometimes it may surprise us as the most severely presented with signs and symptoms that are really fulminant, sometimes may even have the best outcomes. Versus other smoldering ones may actually have worse outcomes. So part of it is recognition, diagnosis, and also the ability to potentially recognize it early and get the appropriate treatment. And this slide actually showed the last 10 years, actually that was actually published at the turn of about 10 years ago, the overall experience at Johns Hopkins where they actually look at a large number of patients that undergo biopsies for evaluation of cardiomyopathies. And interestingly, about half of the patients we still classified as so-called idiopathic, which means that even with histologic recognition of different features, we still are yet to actually identify specific causes. And you can see that patients who have infiltrated disease and patients who have chemotherapy actually are quite severe in their prognosis. And the outcomes of HIV cardiomyopathy actually is much better now. In fact, most of them actually survive to a certain degree. We almost have a paucity of these cases in our population these days. So let's run by a few cases. This is a 36-year-old man with occasional dizziness and some dyspnea on exertion was referred to you for evaluation. On physical examination, there's a loud S4 and a 3/6 systolic murmur at the left sternal border that increases with Valsalva and decreases with squatting. You obtain an echocardiogram, and you will expect to see A, dilated left ventricle, B, moderate to severe mitral regurgitation, C, septal hypertrophy with systolic anterior motion, and D, mitral annular calcification. The feature of this question is to tell you three things. Number one, you'll be reading a lot during the test. So sleep well, because it's actually, many of them are very long. The second thing is that they would actually emphasize a lot of the physical exam and cardiology testing. So learn those very well, because that's also the reason why hypertrophic cardiomyopathy, which most of you actually picked, is actually a favorite topic. So what is hypertrophic cardiomyopathy? It is actually the most common cardiac genetic pathology that is clinically significant, because it does occur mostly about 60% of up to 9 genes to 11 genes that is known, and it causes significant pathology, as you can see in the septum here, that is very thick. It actually manifests in a wide variety of manners, from completely asymptomatic to sudden cardiac death or progressive heart failure or any of these combinations. The natural history really has been described in great detail for the last 50 years, mainly comes from an intrinsic defect that causes hypertrophy. In fact, most of the time now, people think this actually is a compensatory mechanism where there's an overdrive to compensate for this sarcomeric mutations or other kind of mutations. There's actually some degree of diastolic dysfunction in a subset of patients, and as it gets thicker, it's like a blockage of the narrow passage of the left ventricular outflow tract. So there's progressive obstruction in the large majority of cases that actually causes significant and progressive ischemic as well as obstructive symptoms, sometimes coexistent with mitral valve regurgitation or other abnormalities because of the distortion of the anatomy. About 20% of the patients actually progress into overt signs and symptoms of heart failure, and sudden death is actually quite common, although in the grand scheme of things, it is also a challenge because only a subset of these patients do develop sudden cardiac death, with the majority of patients actually considered for at risk. So this slide is actually quite important because this is actually what most of the boards actually would look at. Most people are asymptomatic, although pulmonary congestion do occur in some patients at maximum exertion when the obstruction is severe. Most people do present with one of three things: chest pain, which is really a mode of ischemia, both from obstruction, lack of flow, as well as the hypertrophic hearts that needed more endocardial ischemia. Syncope does occur, similar to aortic stenosis. When you actually had significant obstruction, you do present with syncope. A good number of people had kind of congestion intracardiacally, causing atrial fibrillation, and clearly at the end, more end stage, more impaired cardiac output. Sudden cardiac death, arrhythmias, non-sustained ventricular tachycardia, and others do occur in a large majority of cases. And it's estimated about 1 to 3% per year. Physical exam really is coming down to the characteristic, especially obstructive physiology. And there are some distinction between that and a fixed obstruction like aortic stenosis. And so that's actually one of the favorites in the board exams. Usually they have bisphendian pulse, which is actually the original description with a forceful point of maximum impulse and apical systolic frill. The stiff heart in some patients do manifest an S4. And the systolic murmur is a very important part. I actually did present that in the slide, in the question just now. It actually increases with Valsalva. This is kind of one of the very few murmurs that would actually be exacerbated. It also decreases with squatting. And actually, when you rise up again, it actually increases again. Now, the Valsalva obviously is the second phase where you're actually holding. But the clear picture really comes further with the evidence of left ventricular hypertrophy, which has to be distinguished from a normal variant of a young individual. And the gradient on EKG, on echocardiogram would increase with any type of vasodilatory response like amyloid or even a stimulating increasing contractility like isoproterenol. So there are maneuvers, and I mentioned some, but one of the most famous one is actually the Brockenberg response, which really is a reduction in the pulse pressure, the systolic and diastolic difference after PVC. Most people think of that as the upswing of the LV systolic pressure, but it's actually the reduction of the pulse pressure right after the PVC, and that's really as a result of the changes in the physiology in the setting of a obstructive left ventricular outflow tract. So the treatment of hypertrophic cardiomyopathy actually is several-fold. The guidelines of this actually is going to be revised this year. So the good news is the boards are not going to ask you to read the whole 112 pages. But there are some changes, but at least for now, we do recommend our patients not to go into varsity sports. We do see some consultations like this for athletes that actually noted to have thick hearts and trying to figure out whether they could go into really strenuous exercise. The relief of symptoms actually is negative inotropy. We actually try to relieve the obstruction by actually reducing both the systolic inotropy as well as the reducing the heart rate to try and increase filling. So sometimes we do try very hard with medicines like beta blockers, calcium channel blockers, disopyramide, and diuretics for congestion. Pacemakers have been a hype, but now it really has not actually panned out to actually improve. Septal myectomy really is the treatment of choice in significant cases where medications are unable to correct. Patients actually underwent myomectomies actually had a relatively normal lifespan, so this is actually quite important. And for those that are actually a high risk of surgery, alcohol septal ablation is actually indicated in some. And the subset of patients that develop progressive, quote-unquote, burnout hypertrophic cardiomyopathy actually receive cardiac transplantation without significant changes in their subsequent outcome from those who have other causes. One important thing to consider is those that actually should be considered for defibrillators. So if you think about it, it's actually most people that have significant obstruction as well. Patients who have very thick ventricular walls, family history of sudden death, or prior arrest. Obviously, those are clinical criteria as well. Abnormal blood pressure response to exercise. This is actually quite important. When you put somebody on exercise and they actually find themselves having some dizziness, always think of obstructive hypertrophic cardiomyopathy because the inability of the output to actually augment in response to the need for the body's cardiac output. So the evidence of myocardial ischemia also is a concern, even though the heart may not be as weak for the prophylactic indication. And of course, if there's a significant gradient that you can generate from an echocardiogram. The last 3 years, there has been extensive, should I say, data as well as potential broad adoption of the importance of genetics, and I think there may be some questions related to the appropriateness, also the prevalence of genetic determination. So that's actually an important thing to understand. It certainly was there in some of the boards that I took. The genetics of hypertrophic cardiomyopathy is actually clinically available now. You can actually order it. There are 4 companies who runs it, and it actually comes up with the 7 to 11 genes that you can actually look at in its entirety to look at more than, there's a large number of mutations available. And most of it is looking at the sarcomeric proteins, looking at changes in specific mutations. There's also some so-called phenocopies. They are actually mimics of hypertrophic cardiomyopathy, which are not sarcomeric gene mutations, but potentially a mitochondrial dysfunction or actually infiltration of glycogen that are deposited, and many of them actually have also changes. So what about screening? Currently, since about 60 to 70% are genetically linked, clear family history is common, and there are many patients, especially kids, who actually have genetic abnormalities that now we are finding. This is the old guidelines that would probably change in a bit with some genetic information. But if you're less than 12 years old, most of the time before puberty, you actually don't get the growth that's needed for worsening hypertrophy. So most of the time when you do an echo, and most of your patients' kids would actually get the echo and say, oh, it's normal, but they are only 6 years old. Many of times they are normal, and they would actually develop over time. So when they're getting older, between 12 and 18, especially if there's a strong family history, you should get a repeat evaluation. For those with very strong family history, you do get one before 12 years old. And then some mutations actually develop at the age of 30 and 40. So having a normal echocardiogram still does not completely exclude it. And that is the potential benefit of genetic testing, where those that does not carry a mutation that is pathologic can actually avoid this quite common and frequent screening pattern. It's important to distinguish this from athlete's heart, which is also a hypertrophic response to exercise. If you have high-level athletes who actually had hypertrophy and dilatation, most of them do not dilate up to 1.4 or 1.5 centimeters in terms of their ventricular thickness. So they usually have large cavities rather than small cavities, and they are usually not stiff in their heart. So these are more specific, but that's certainly a very common clinical encounter. The next is really restrictive cardiomyopathy. This is actually common, particularly in more specific scenarios or infiltrative diseases. You do see that in elderly gentlemen or young kids alike, but with very different causes. Two main causes that I actually highlight, one of them is called amyloidosis, which is a systemic disease with amyloid deposits abnormally in the ventricle, in the myocardium. In fact, most of the time it actually is diffuse. And there are very different types. When you actually evaluate somebody with amyloid, you do need to understand whether there's actually a primary bone marrow abnormality or versus a primary liver abnormality that actually make abnormal proteins like transdiethrin. Because the treatment may be very different. Nowadays, we do give chemotherapy to subsets of patients who have direct evidence of AL amyloidosis, and some of them actually have great responses. Also, not all amyloidosis in the past that we actually exclude them from cardiac transplantation, now some of them actually are eligible because of their longevity and their number of organs that are affected. So direct staging and classification is actually vitally important. The other one is Fabry's disease, which is the deficiency of some enzymes that actually breaks down the proteins that actually ended up depositing in the heart. And it actually can be diagnosed with or without the genetic testing. And the treatment actually is some form of enzyme replacement that you can actually give. Usually they come as referral in the sense that they could have other systemic neurologic or other conditions that actually come with a cardiomyopathy. And subsequent treatment always result in decrease in progression. So the second case is a 28-year-old lady present with recently diagnosed with asthma and treated with inhalers without improvement. She presented with progressive worsening right upper quadrant pain and some sludge in the gallbladder and abdominal ultrasound. On examination, she was tachycardic with a blood pressure of 95/58, an elevated jugular venous distension of 10 centimeters, S3 gallop, and a 2+ edema. An echocardiogram demonstrates dilated cardiomyopathy. Your most appropriate next step should be A, perform an endomyocardial biopsy, B, refer for genetic testing, C, initiate loop diuretics, D, check a BNP. This slide shows you the two common second diagnoses. Some of our patients do come in after gallbladder surgery, found out that it didn't get better, and others actually have asthma. And so the answer actually is true, is initiate loop diuretics. And sometimes many of these questions may be even more obscure. Maybe they would actually ask for other things that you kind of immediately think about it. But the clear here is that if somebody is congested, no matter what is the underlying cause or effect is, just like what you hear from Dr. Sheesh's talk, maintaining euvolemia is a very important part, and that's why this is actually the right answer, initiate loop diuretics. So when it comes to dilated cardiomyopathy, which is what this patient actually presented with, notice all these patients are actually quite young, and many of times you actually do not see the average heart failure presentation that Dr. Ashish actually presented. But that's directly looked at patients who have ventricular dilatation, which is actually more prevalent than once thought, particularly in the familial sense. About a quarter, if not even more patients actually present with dilated cardiomyopathy. And you can see without even measuring that the heart is grossly abnormal and it's very different from a normal counterpart. The most important thing to understand dilated cardiomyopathy, to understand its potential reversibility. There are some patients that do reverse dramatically with medications, and there are some that even reverse without any specific medications. Many of them comes from extrinsic causes, and some actually from neurologic changes that we're still evolving in our understanding. So this lists actually a common group of causes, and many of them you may actually encounter during your question and answer in the boards. In particular, alcohol and some of the medications, especially chemotherapy. I'm going to extend it a little bit. It is also common for us to see endocrine abnormalities, ranging from patients who have thyroid disease or acromegaly or any other endocrine abnormalities that actually involve the heart. There are also infective causes, and that's actually not uncommon. Myocarditis is actually commonly associated with virus or bacterial carditis, really inflammation of the heart. The diagnosis for a long time is also a histologic diagnosis. You can actually see the leukocytes actually causing cytotoxic damage at the level of the myocardium. This has to be distinguished from two other specific conditions. One is called sarcoidosis, which is rather granuloma infiltrate, as well as giant cell myocarditis. The latter two actually is quite important because they actually fare poorly. In fact, giant cell myocarditis is one of the main reasons why you need to consider a biopsy in a patient coming in with myocarditis. Usually they present with fulminant cardiomyopathy. They may have significant ventricular tachyarrhythmia. They may be unstable, and actually moving directly to urgent transplantation or ventricular support is actually important. Most of the time, there's been a lot of text thinking about serologic diagnosis, but that's actually quite unuseful. Their specificity and sensitivities are quite low, so we usually do not perform that. And it's very supportive, but ultimately moving in directly to more advanced support like balloon pumps, ventricular assist device actually helps in a lot of patients. Interestingly, those people that fulminantly presented with cardiogenic shock or other conditions, if they actually recover, their prognosis is excellent. Versus those that have smoldering problems, they could actually get worse. And this is data from the Johns Hopkins experience. This is a laundry list of patients who have potential causes of myocarditis. It is important for you to understand that there is a wide range. In fact, almost all bacteria and viruses have been associated to that. There's also specific toxins that I need to point you out to, especially drugs of abuse, cocaine, or any sympathomimetic drugs. Ephedra is quite common. Patients may have cold medicines or actually weight loss medicines or bodybuilding medicines that they actually take even 3 or 4 or even 5 years ago that subsequently present now with cardiomyopathies. And the cessation of these usually has some improvement, especially together with medications. There are some environmental exposures that you should look at, a very important employment history. And there are many, many medications that potentially cause that too. Two particular scenarios I need to discuss. One is actually peripartum cardiomyopathy. The definition is quite specific. It's the 1 month before delivery and 5 months after delivery, where an incident development of new onset heart failure and cardiac dysfunction occurs. We don't know exactly why right now, although there are some pathologic diagnoses that suggest that. It is more common in older women, in multiparous women, and especially in African Americans. In fact, the highest prevalence is actually in Haiti, and the world's expert is currently residing in South Africa. So Africa actually has the most in terms of peripartum, but we do see commonly, occasionally, and the main reason why I express that is because this is probably one of the most lethal conditions of pregnancy, and it's important to recognize that. The treatment right now, at least during pregnancy, is to avoid drugs that actually have teratogenic effects like ACE inhibitors, ARBs. Hydrazine acetate is actually safe. Loop diuretics is safe, although the obstetricians will actually argue about how much you use. Beta blockers has suggested with intrauterine growth retardation, but actually it's also very safe. All of them has a class C indication, not class C, but the safety pregnancy level is C. And after pregnancy, it's important to actually give back all the medications as standard heart failure treatment. And even about half of the people do respond. The subsequent pregnancies remain high risk. On average, they would have 10 to 15% ejection fraction drop, even if everything goes very well. So we always advise against subsequent pregnancy. Another condition that is common in the medicine literature is chemotherapy-induced cardiomyopathy. Again, this is a condition that is actually more common than we think. And the problem that we face is that when the condition developed, most of the time, they actually already had full-blown exacerbation. Interestingly, chemotherapy-induced cardiomyopathies do not dilate. They actually had a direct damage to the myocardial cells, and so the actual compensatory mechanisms are at risk. Adriamycin is really the hallmark of it, although there are many other drugs. In fact, the first four that you can see are all drugs for breast cancer. So any of them could actually cause direct myocardial injury as well as myocarditis. So there are sometimes when you see transient changes also during chemotherapy infusions. The other drugs, midostaurin, is actually used in multiple sclerosis, and that actually has a label to say serial measurements. Combination of these obviously is important. If you have trastuzumab and doxorubicin together, there's a much higher risk. In fact, some series even describe up to 25%, 1 in 4 actually can develop cardiomyopathy. Now, cessation of the drug actually does improve its chances of recovery. And we are now having more and more chances of identifying that with troponin rise, and you can see that early treatment may actually improve the outcomes of reducing the risk of subsequent cardiac dysfunction. Again, short slide showing genetic mutations are not uncommon. 20% of genetic mutations are found in dilated cardiomyopathy using a panel. There are some that are quite important because many drugs are becoming to develop more orphan drugs to try and tackle specific diseases. But overall, the treatment, just like Dr. Sheesh has mentioned, ACE inhibitors, beta blockers, aldo antagonists with a bracket in the mild heart failure, angiotensin receptor blockers, and hydrazine acetyl, especially in African American patients. So last but not least, there are some really peculiar ones, especially the right ventricle being weak on its own. This one is actually a very rare disease, arrhythmogenic RV dysplasia. The main reason why that may actually occur in the boards is actually this is one of the very few conditions that really isolated develop to affect the right ventricle. And basically, it is replaced by fatty tissue instead of muscle, and that causes significant right ventricular dysfunction and arrhythmia. So there are specific genetic mutations, and people, most of them actually go through transplants or they die suddenly. So the last slide really looking at the challenges of mutations. I do spend some time talking about the genetic mutation because these are the things that are particularly new and probably will be with us for some time. It is not specific. The hypertrophies and the dilatants could actually happen in the same genetic mutation. The father and the mother and the son could have actually the same mutation but different manifestations. So we're actually evolving our understanding of the cardiomyopathies as it comes along. So last words is really a tip for the boards. Consider cardiomyopathies, especially when they are young, or congenital diseases for that matter, and or having a strong family component. The normal ejection fraction clearly does not exclude cardiomyopathy or heart failure. There are some people that can be symptomatic from one way or another with preserved ejection fractions. And know your physical exam and EKG signs very well, because those are the things that the boards will kind of mandate that you'll be able to understand even at the office. And not all dyspnea patients are heart failure. So there are many asthma patients. There are also some with endocrine or valvular dysfunction. And try to understand what the question trying to ask you. Read all of them. And lots of people are fainting or tired and never straightforward. All right, good luck.